So what's audience? So medical. You can ask questions. So is that like the capital city out there?
Welcome, everyone. I'm just giving people a few more minutes to float in before we get started, but thank you for being here. Just give, let's see, maybe, yeah, 3 more minutes and then we'll get started. Let some people come in.
So Bethel, it looks like I screwed up the time. It's actually 7 p.m. there, huh?
Yes, it's 7 p.m. here.
Maybe I made this slide before.
The daylight saving.
Yeah.
Yeah.
Okay.
Yeah, daylight savings. Yeah.
You
No,
can
that's
see you can see my screen, correct?
yes.
Okay.
Oh. Okay, so Dr. Seth, usually how these forums go, someone starts, well, most things in Uganda, most things start off with a short prayer. Someone's gonna volunteer to do a quick prayer, and then I'm gonna talk a little bit about Busoga Health Forum, introduce you, and then we'll get started. So, if there's anyone who would like to lead us in prayer before we get started, please go ahead and raise your hand so I can unmute you. Don't know if, let's see. Okay, Godfrey has raised his hand, so I'm gonna unmute you and you can lead us in quick prayer and we can get started.
Oh, okay. Thank you very much for this opportunity. Good evening, ladies and gentlemen. This is Godfrey Weha. Nice to meet you all. Let's have ourselves and we pray. Kind and loving Father, we thank you for this opportunity so that we've gathered this evening. We thank you for the upcoming presentation. We call upon your presence amidst us. Guide us in Jesus' mighty name, we pray. Amen.
Amen. Thank you, Godfrey. And it looks like we have a few people in here, so we're just gonna get started. Quickly, I'm going to talk about the Busoga Health Forum. So Dr. Seth, I'm gonna kick you off a little bit. They have a short PowerPoint that they show. So let me share that.
You want me to unshare my screen?
I think I can boot you. Let me see. Yep, I think I can boot you. So just be quick. It's like,
Okay.
yeah. So for those that are new here or not members of Busoga Health Forum is a nonprofit, voluntary, membership-based organization that's located in Jinja City. Dr. Seth, Jinja City is the eastern part of Uganda. They collect professionals, people in the community, government, and other partners to improve the health of people in Busoga and hopefully and beyond. But the biggest mission that they have is to create a healthy, thriving Busoga. And for right now, they focus a lot on health initiatives and education initiatives. Their values are listed here: impact focus, transparency, effectiveness, collaboration, So things like this platform, bringing together professionals and collaborating with different people around the country and outside of Uganda to make sure that we can collaborate and create more education opportunities for our healthcare professionals. Like I mentioned before, it's a membership-based organization. You have the ability to join as an institution or an individual, or they also have a lifetime membership. So if you're interested, their information is right here, their website, Twitter, Facebook, YouTube, and email. If anybody has any questions, I can direct you to the person that can answer any of those questions in the chat. Just send me a message. But we have a lot to cover today, so I want us to get started. Let me make sure I've stopped sharing. Okay, perfect. So our first speaker today is going to be Dr. Seth Koenig. Dr. Seth, am I saying your last name correctly?
Koenig, yeah, and
Yeah,
here,
Koenig.
I'll
Okay.
people can see my beautiful face.
We can see your beautiful face.
Yeah, there you go.
And a lot of people may not have their videos on just because it uses a lot of data here.
No, that's
Yeah.
okay. I can turn mine
Okay.
off as well when we get started.
Yes, yes. So I also think people haven't really seen my face either. But yes, this is Dr. Seth Koenig. He's a pulmonary and critical care trained physician who has spent most of his clinical career both using and teaching point of care ultrasound, which is also known as POCUS. He has used ultrasound in the intensive care units, the pulmonary consultation service, as well as in the outpatient office. He has taught ultrasound in many countries and to many folks, as he says, while he has been at one time or another, chief of medicine, chief of pulmonary and critical care, and medical director of the ICU. His passion is at the bedside, providing hands-on care to his patients while teaching others the art of POCUS. I'm very excited to have him here. I'm very excited for all of you to learn from him, given that we are in a setting where a lot of times we need to make clinical decisions quickly. And I think POCUS is one of the things that is being introduced in a lot of our hospitals, especially, I think I have a few EM people here that are learning and using that bedside. So I'm very excited for them to see and hear from an expert. So Dr. Seth, they are all yours.
Great. Do you want me to, are you going to put my screen back up or should I do it myself?
You can share for yourself, that's fine.
Okay, so here we go. What's up, folks? Please, for me, and you guys can decide for yourself, but I kind of like to have a back and forth. So please don't be afraid to speak up and to interrupt me. And I mean that sincerely. I think the beauty of didactics gets lost if you just listen to me speak, especially if you have a question that I might be able to answer right away. So this might be the farthest I've sent a signal, I suppose, because I did do this in the Congo, but that's a little further west. So I'm kind of happy. And really, it's great to be here. And I know Moses, who will be joining soon, I think he told me very well. He was my fellow, so I had to, kick his butt into shape when he was here. And so he obviously, as you guys know, is just not only an awesome human being, but just a great physician. So I have some learning objectives, and this is what I'm putting down. And again, I'm not going to talk that long. First of all, they say you have about 10 minutes of attention span, first of all. And second of all, no one wants to hear somebody blab on. But what I kind of want to just bring your attention to it, and we can do this in the future in a different way, which I can explain to you at the end of this. But the idea of taking POCUS is to figure out how to accurately rule in, and then also importantly, rule out a diagnosis, because sometimes you can't make an actual diagnosis because there may be many things that could cause the same problems, but sometimes it's important to rule out a diagnosis. For instance, a massive pulmonary embolus or a bad pneumonia or a large pleural effusion. And that obviously we'll get into. You can efficiently make a diagnosis. What does that mean? It's that people believe, and these are people from, probably before the age of POCUS, that you need to call a cardiologist to make and get an echo done by an individual to figure out if the heart's working. You need a CAT scan of the chest and so on and so forth. But that may not be true in many situations, and you may not be able to get them in many situations. Then the most important thing is really to help answer the question you're asking. And I'm going to say this over and over again because, you know, my son, who's not a doctor, can learn how to do point of care ultrasound just as good as I can. But if he's not asking the correct question, then what we're seeing is not really going to help him. And really, you're asking the simple questions up front, like, why is the patient in respiratory failure? Why is the patient in shock? And then I'll go over a couple case examples and, you know, some of the basic ultrasound. So I think that I learn best by going through cases. And I'll just start off the topic by saying this is a patient that you may have seen all the time, right? A young male who has sickle cell disease, who develops chest pain and has hypoxemia, right? This is not an uncommon problem. And he comes in, he's got chest pain, fever. He has a history of acute chest syndrome. So you already know that that's, you know, part of your differential diagnosis. There's a question in the chart that maybe he has pulmonary hypertension, which would be very important to know, especially if you're going to volume load an individual. There already is evidence of hemolysis, and a lot of these people have, you know, chronic low-grade hemolysis. The physical exam is typical for sort of anybody who may have pneumonia and who's sort of in respiratory distress, right? His heart rate's fast, his oxygen level is low, he's got shallow, rapid breaths and some crackles on his exam. And so what is your differential diagnosis? Well, I mean, is it acute chest syndrome, which he's had in the past, and one sometimes begets another? Does he have a PE, right? Everybody worries about the dreaded pulmonary embolus, and sometimes that's not so simple to rule out. Is it pneumonia? And sometimes the distinction between pneumonia and acute chest syndrome is not so simple. Is it atelectasis, and etc. And then you can add to your differential diagnosis, obviously, the local phenomenon that you have, right? So I don't have certain diseases that are going to be where I'm sitting that you have there, but that's not really what's most important. What's most important is you start putting your diagnosis in a bucket. You know, is it a lung problem? Is it a heart problem? Is it something else? Is it metabolic? Now, this person, because we live in a very medically rich society, this guy had 6 CAT scans to look for PE in the last 14 months. So every time the guy comes in with some chest pain, he gets a CT pulmonary angiogram. He's had 3 DVT studies, 2 echocardiograms. And so this would be a typical patient that we would see in our hospital. And then you'd ask yourself, well, what's the plan, right? So this was a chest radiograph, right? So I don't need to go into detail, but I think all of you would recognize that this patient has a pretty sharp, you know, right side, right? The diaphragm meets it. There's no evidence of anything that looks suspicious too much on the right side. The left side, it's hard to say. There may be something going on behind the heart here. Maybe there's some vascular markings, but again, you see beautifully the hemidiaphragm here. It's not silhouetted out. So what are you going to do, right? In our emergency room, this patient was already ordered by the time I saw the patient for a CT pulmonary angiogram, which would be the 7th, an echocardiogram, and a lower extremity ultrasound. And so what actually happened? So this was a real case. My residents have been heavily trained, at least the ones that we've had the opportunity to work with, have been heavily trained in point of care ultrasound. So what happened was the hospitalist came down with the resident performed a POCUS, and they called me after that. They said, well, there's an alveolar consolidation that they didn't see on the x-ray. There appeared to be right ventricular dysfunction. And I'll, go over what's the difference between sort of dysfunction and failure. They gave the patient diuretics. There was no evidence for a DVT. They ordered a red cell exchange, and that took 5 minutes. And this is no BS case, like this actually happened. And so, we'll talk about this. So I leave that for you, and we'll get into it, and I'll show you the images that they acquired in a little while. So what is point of care ultrasound? Well, I'm assuming you guys have started this conversation. it's hard not to in the, this age of smaller and smaller ultrasound machines and technology. But the difference is, right, that we are performing the actual exam, and we do our image acquisition, our interpretation, and then what is most important, which is not what a radiologist or an ultrasound sonographer does, is that then we have to clinically integrate that data. And that's the big leap as compared to consultative radiographic studies, right? When you ask someone to do a CT that's read by a radiologist, they're going to acquire the images and interpret the images, but they are not at the bedside. And so the exam that you're performing is really, it doesn't have to be a comprehensive exam. You are simply answering a question you've already asked. Why is the patient hypoxemic? Why is the patient in shock? Why is the patient not peeing? And so in that way, the exam may be limited, and then you can repeat it, right? Go try to get your cardiology group to do an echo 2 times a day for the next 3 days in a row, and you'll find that they just don't have that capability, right? And so why do we do this? Well, clinical dissociation is really hard, right? So you have a person who does an echo, they don't know anything about the patient, they give you a reading, but that's not what you asked. You may have said, why is this patient's legs blue, right? And so they may say your echo is normal, but did they tell you what the cardiac output was? Did they tell you if the valves are okay? When you ask the question at the bedside, you get a better answer. There's no time dissociation, so you're not waiting for the exam. You don't have to move the patient. There's really no radiation. You spend more time with the patient. I can't begin to tell you, maybe you folks do a better job than we do here, but I can tell you here, we spend very little time next to the patient. We spend most of our time in front of a computer, asking the computer to help us do something. And it's highly accurate. That's what you want to know. I mean, anybody can put a probe on somebody's chest, but you may not know what you're looking at, right? So it has to be accurate, which is going to come with both from the technology side, right? You have to have an ultrasound machine that actually gives you images that are worth reading, and then you have to be good at it, right? So you can rule in and rule out a diagnosis. So for instance, if a person's in shock in front of you and the right ventricle is not dilated, it is not a massive PE. Now, I didn't say they couldn't have a PE. I said it's not causing the shock because the RV must dilate. So that's very helpful. You have a person in shock, even if they have a DVT, you look at the RV, it's normal in size. You go, okay, well, it's not a PE right now. Maybe they have something else going on. B-lines, we're going to talk about this a lot. That is the lung ultrasound artifact that suggests pulmonary edema. So if you have somebody who has known severe heart failure, who comes in breathless and a little hypoxemic, and you do a lung exam, which takes 10 seconds, and you don't see B-lines, well, it's not. And I repeat, it is not pulmonary edema. Now, that doesn't mean they're not in heart failure. It doesn't mean that they don't have pleural effusions. It means at the moment that you're doing it, they're not in acute pulmonary edema. And then an alveolar consolidation, right? Looking for somebody who has an infiltrate. So if somebody comes in, I don't know how many times I hear people tell me, oh, the breath sounds are normal. And then I look with the ultrasound and there's a big consolidation posteriorly. So if a person has a fever and a white count and they're coughing up green sputum and you see a consolidation, well, then clinically, when you integrate the acquisition and the interpretation of the image, you're going to say, well, that's pneumonia. And so my 2 warnings, and this I see every single day when we were teaching. POCUS must never be performed in a vacuum, meaning you're not a cardiologist doing an echo and then reading it and sending it to someone else. You must be asking a question. And the clinical history, the surface physical exam, and POCUS has to be put together to make this make sense. So we'll go through sort of a little bit of a quick primer to see how to integrate this, and we'll go over the case of the sickle cell patient in a moment. So what are we talking about when we want to learn how to do POCUS? It's really thoracic ultrasound, which is the lungs and pleura, cardiac ultrasound, which is a basic 5-view exam, abdominal ultrasound, you want to look for a fast exam, right? Are people bleeding into their belly? You want to look at the bladder if it's over distended. Does the kidney show hydronephrosis? Or, is there a big mass sitting in the liver? And then vascular diagnostic is going to be a DVT study. Just this alone really, really helps. So again, let's start with thoracic ultrasound. Why does the patient have hypoxemia, chest pain, or dyspnea? You start with your ultrasound to categorize the problem. What do I mean? Well, if a person, everywhere you put the probe, shows a normal pattern, and I'll show you that in a moment, well, then they have dry lungs. That's it. I mean, it's as sensitive and specific as almost 100%. So you know they don't have a big pneumonia, big pleural effusion, cardiogenic or non-cardiogenic pulmonary edema. Maybe they're wet. And if it's wet, is it unilateral or bilateral disease, right? So if it's a unilateral wet lung, that's less likely to be cardiogenic, okay? Is there a consolidation? And if there is it pneumonia? Is it atelectasis? Is there a pleural effusion with it? If there's a pleural effusion, is it simple? What do I mean by simple? Simple is not a diagnostic term here. Simple is it's just black. It's just anechoic, we would call it, meaning you don't see any septations in it. It doesn't look ugly. So simple tells you something. Complex tells you something else. You might see things floating in the fluid, or it could be septated. But honestly, you're asking yourself two questions. You're saying to yourself, can I drain it? Meaning, is it big enough to stick a needle in? And the second follow-up is, should I drain it? And that's going to be based on the clinical context. So if you have a simple pleural effusion that's moderate in size and a febrile patient who's coughing up green sputum, you're going to make an assumption that this is a parapneumonic effusion and you may want to drain it. On the other hand, you may have a simple, moderate-sized pleural effusion with a person coming in with lower extremity edema and a history of an ejection fraction of 20%, and you may say, well, that's probably just hydrostatic fluid. We need to give diuretics. And so that's the main way. You have to be asking the clinical question in order for us to make sense of things. And in red here, I obviously put the red around this, this infiltrate, I would call this hazy opacification with silhouetting of the right hemidiaphragm. And I call it that way because that's the radiologic way. When you say infiltrate, you've already put a clinical diagnosis. And let's face it, they would read this as infiltrate versus consolidation versus pleural effusion. Well, you want to get more specific than that, and that's where the ultrasound will be helpful. So the first thing I always put on the screen is what's normal. And so I have what's called a phased array probe that's just sitting on the person's chest, way up superiorly in the person's chest, and they're just breathing back and forth. And I write this here that to the naive clinician, this is an absurd looking thing. It doesn't, why would anybody use this? But once you figure it out, it's much better. So what is this? This is all an artifact. The only thing that's real is where the blue line is pointing to. This blue line, this is your pleural surface. And if you watch carefully, you see movement along this surface. That movement is the parietal, the visceral parietal interface where the person is breathing in and out. And this tells you that this is normal, okay? Now there's two things you see here. It's very hard to discern, so you're not gonna be able to right now, but you would see this movement with breathing. So if you tell them to stop breathing, you move out, you take away the respiratory movement, but you still have cardiac pulsation. So if we told the person to stop, you still might see this beating, and you can actually use that to show that the patient's heart obviously is pumping. So again, this is normal. And so if you take your probe and you put it anteriorly on both sides, then you move it down a little bit on both sides, then you look at on each side, and all you see is this, you can say very, very confidently, there's no big pleural effusion, no alveolar consolidation that must be causing any major issues, and certainly the person is not in pulmonary edema. And if you think back to what we're saying, if a person comes in hypoxemic respiratory failure, and this is what you see, boy, you better think of some other things quickly, like, do they have a DVT and is the right heart dilated and they have a massive PE? Do they have a shunt someplace? Because you got dry lungs. And that's the point of doing this very quickly, okay? So what does the ultrasound tell us? This is a normal aeration pattern. There's no evidence for alveolar consolidation. When they used to do, when this was first coming out, they used to do these on people who had right heart caths in. And basically, they were always just about under a wedge pressure of 18. There's no pneumothorax. Well, why is that? Well, the only way to see movement along the pleural line, remember that would be the visceral parietal pleura together. If you have air that's between the visceral parietal pleura, i.e. a pneumothorax, right? A pneumothorax separates the parietal pleura, which is sitting in the thoracic cavity, and the visceral pleura, which is sitting on the lung, you would lose this movement immediately because the ultrasound, once it hits right here, as soon as ultrasound hits air, it bounces back. So the reason why hopefully all of you who are listening to this should have this, because if you don't, something's wrong. So remember, ultrasound does not like air. It will bounce back. So this is the only thing you should see. So then there are things below it. And I'm not going to get too deep into any of this today because, like I said, if everybody's interested, we can start to discuss them on individual basis. So in other words, we can do a lecture just on thoracic ultrasound. But what you see below it are these lines. These lines are what we call reverberation artifacts. It hits here and goes back, but sometimes the ultrasound just gets caught up in here and it thinks that these exist. And again, I don't want to go too much into it today. So what do other findings look like? Well, here on the left, this is what a alveolar consolidation looks like. So I'm going to make this statement. If you see into the lung, meaning there's no longer that artifact of the lung moving back and forth. If you see deeper into the lung, something's wrong. You should never be able to see deep into the lung because there should always be air there. So this is an alveolar consolidation pattern, and all these white dots are little bits of air that are stuck in the consolidation. And watch when the person breathes, you see this air moving right here. You see it coming up and in, right in this region. That's called a dynamic air bronchogram. And a dynamic air bronchogram is consistent with, but not diagnostic of, a pneumonia. Does somebody have a question? Okay. So please, chime in if you do. Now on the right here, we see these lines that are shooting down from the pleural surface right here, all these things. As the person is breathing, you can see these lines that come all the way down. Now remember, let's go back to here. This is normal, okay? And this are these lines that are shooting down. This is pulmonary edema pattern. These are B lines. They move with respiration. They're moving back and forth when the person breathes. They go all the way down to the bottom of the screen and yada, yada. We can go more into that in the future. So these two things, this is a consolidation, this is pulmonary edema. Now it doesn't tell you what type of pulmonary edema. It just tells you pulmonary edema. Remember, pulmonary edema can be cardiogenic. It can be non-cardiogenic. Lots of things cause non-cardiogenic pulmonary edema. In fact, COVID, we lived our lives talking about B lines that were non-hydrostatic pulmonary edema. And so what about this B line, right? So here it is again, you'll see it coming right across. It shoots down right here. It moves with respiration. It reaches the bottom of the screen. It gets rid of those other lines that were there. And this really helps determining your clinical problem. So if you see this on both sides, right and left, everywhere you put your probe, this is pulmonary edema. Then you ask yourself, well, is the heart bad? Do they have pleural effusions? Do they have a history of heart failure? Maybe it's heart failure. On the other hand, maybe they have COVID, a virus, influenza. Maybe they were just given chemotherapy that causes a pneumonitis. So these are the ways that you have to think about these, because otherwise it's just a B line. It doesn't tell you anything. Here, it's even more diffuse. You can't even see the one line coming out of it. Here you can see some individual lines. This is just one big beeline. There's so much pulmonary edema that it's all just crowded in there. Here would be one that you can see a little bit more, right? You can see it coming down and splitting down here. So this is a little bit less. So the point is that you need, once you learn the image acquisition and the interpretation, you then have to put that and consider what it is based on the individual that's in front of you. So why is the patient hypoxemic? Will the chest radiograph answer it? Will the stethoscope answer it? I mean, you know, I'll leave that up for debate, how we use our stethoscopes. I mean, nowadays, if we can get one that's AI and just tells you what the problem is, I suppose that would be great, but it's not there yet. So what I say, are the lungs wet? Okay, does it look like this? If it does, the lungs are not wet. If you look everywhere and that's what you see, these lungs are not wet. Is there a consolidation pattern? Is there a pleural effusion? Does it look like this? This is another example of an alveolar consolidation. This is the hemidiaphragm here. And what did I say? If you can look into the chest, something's wrong. So this part right here is all consolidation, and the white within it is air. There's a little pleural effusion that you'll see right here, this black right here. And you see the upper lobe when the person breathes moving into your screen with some B-lines on it. So this could simply be a small paraneumotic effusion with an alveolar consolidation consistent with, I don't know, name it, pneumonia, nosocomial pneumonia, hospital-acquired pneumonia, you name the pneumonia, okay? So that's how you would do this. So the etiology of the hypoxemia in this person, it's probably pneumonia with a small paraneumotic process. Now in our world, I can tell you, everybody and the mother and the dog will get a CAT scan because people don't accept what they might be able to do themselves, and they have to have somebody else tell them. And I get that. But as you arm yourself with the power to do this, it's just a big waste of time and money because this is perfectly acceptable. Okay, so does the patient have a consolidation, a paraneumotic effusion, both? So do you need a chest CT to characterize a pleural effusion? Well, in fact, CT is less specific to characterize an effusion. I've seen so many CTs being read as empyemas, and they're not. I've seen them read as loculated, and then I drain them completely dry. And so in our world, and Moses will be able to tell you, because I probably said this 1,000 times to him when he was a fellow, is don't send a patient for a CAT scan before you do an ultrasound. Tap it if there's an effusion, let the lung expand, and then do a CT scan if it's needed. And then the same thing with the unilateral whiteout. I mean, it seems absurd to me to do a CT scan first, because you'll know immediately whether you're dealing with a pleural effusion, consolidation, both. You'll be able to see if it's pushing the diaphragm down. There are so many things that you can do. So just so that everybody's on the same page, this here is a diaphragm. The black, we call it hypoechoic. Well, how the hell do we know if it's hypoechoic? We have to know what echoic is, right? There's hyperechoic, hypoechoic, and anechoic. Well, anechoic is no sound that is sending back, so it looks black. So anechoic looks black, hypoechoic looks a little less black, but pretty black. And if there is an echoic surface, then that means you can see it. So for instance, the hemidiaphragm is echoic. You can see it. It sends echoes back to the ultrasound, which then registers it at some level of gray. So the more that bounces back, the more grayish white it's going to be. And so for a pleural effusion, you need to see the lung, which is flapping around in here. You need to see the hemidiaphragm, and you need to see this hypoechoic space. So what do other effusions look like? Well, this person came into the emergency room after being stabbed. So what do you think this is? That's a hemothorax. It's all this fluid that's sitting here. Okay, now, does it have to be a hemothorax? What if a person comes in with 104 fever, hypoxemic, coughing up with a white count of 50,000? Maybe that's an empyema. What if a person has a known lung cancer who's been getting more and more short of breath? Maybe that's a malignant pleural effusion. The one on the right here, those are septations. Again, it looks lacy. It looks like a, sort of a spider web. And again, what is that? I don't know. Could they have an empyema? Sure. Could this be rheumatoid arthritis that went too long? Sure. Could it be a cancer? Sure. Again, the question is.
So I'm going.
Hi, Patrick.
Finished.
There we go. Okay. So,
Patrick, could you mute yourself?
do you have a question? Okay.
Sorry.
No worries. Point of care echo. So now let's move from the thorax. There are a limited number of views. And again, let's be real. You're looking to see why somebody's blood pressure is low. You're looking to see if there's a life-threatening process like a huge PE or a big valve that's got a hunk on it, right? Or a big pericardial effusion. So you can categorize the shock state and then manage it and then follow it. And all we do are 5 views. Again, you'll learn these if you want, or some of you may already know. Parasternal long, short, apical floor, blah, blah, blah. So what are we going to look for? Well, hemodynamic failure has many causes. Sometimes it might not even be just one cause, right? A person could have a severe LV dysfunction from a sepsis-induced cardiomyopathy and their blood pressure is low because they both have hemodynamic failure from the heart, but also vasoplegic, meaning they have a distributive shock state. And the goal-directed echo will allow you to see these, especially the ones that are life-threatening, right? And you can do them anywhere you want, okay? So like, for instance, this one on the left, there's a subtle finding here. I say that obviously in jest. This was a woman who just gave birth to a baby, and that's the baby in the right side of the heart. No, she all of a sudden dropped her pressure and was in the OBGYN suite. They called heck loose over the loudspeaker. And when the resident and I got there, there was pure and utter chaos. And there's 3 anesthesiologists, OBGYN there, take the patient to the CAT scan, let's intubate the patient, what's going on? And my resident, because they were all talking over each other, she was small, she went right up in there while they were talking and did the ultrasound of the heart and just went Koenig. And I took a look over and I saw this big clot that was sitting in the right atrium trying to get into the right ventricle with a very dilated heart. So while all of them are making noise, we ordered TPA and we gave TPA to the patient and she did just fine. And this was the clot in her leg right here. So when you see she pushed up on it, watch, this is a clot. And so could you imagine, you may not realize this, but you intubate a patient who's got this amount of right heart failure, you can kill him immediately. And what the heck are you going to get out of it? So she was hypoxemic. Well, if you would have intubated her, she would have remained just as hypoxemic. So that's the point. The point is that you want rapid analysis. Okay, so now back to the sickle cell patient. So remember that chest radiograph. It really wasn't that abnormal. Look at the size of this alveolar. Here's the hemidiaphragm right here. This is on the left. There's a huge alveolar consolidation pattern at the lower part of the lung with the dynamic air bronchograms. That's these white things moving back and forth. And when we repeated the chest x-ray, that's the first chest x-ray. That's the second one. Now you can start to see on the left here, silhouetting of the hemidiaphragm. There's hazy opacification. That's either going to be a pleural effusion or it's going to be alveolar consolidation. And so you see, you didn't need the CAT scan. But then we went on and we said, this person has a history of potential pulmonary hypertension. So again, I don't expect you to know all this at all, but this is a normal beating heart down at the bottom here on the left. The walls come together. This is mitral valve here. There's an aortic valve here. So if you compare this with this, it looks different. There's this dilation right here That's called the coronary sinus, which gets dilated when there's increased right atrial pressure. There's a little pericardial fluid sitting here. And up here is where the right ventricular outflow tract sits. It's very big. Again, how do I know it's big? Because I looked at many of these. There's no rocket science. It's just look at these and compare. So if you come over here to the right, this is now what we call a short axis view, where you're just looking at the heart contracting. This is normal. So if I put the pointer right in the center there, you see all the walls come together and it's contracting well. This was this guy's. The right ventricle's humongous, and this is the septum. And this is what you may hear when people say there's interventricular interdependence or D'ing of the septum. This person has both pulmonary, both systolic and diastolic D'ing, meaning it never completely rounds out, which means the patient has both pressure and volume overload. Why does that matter? Because guess how much fluid we give our sickle cell patients, right? That's like in the books. Flood them. You gotta get those sickle cells to not be so bad. Well, if you do that with this guy, which is what happened, he's gonna go into right heart failure, which is why we gave him diuretics, okay? Now here's the 4-chamber view. Left ventricle, right atrium, left atrium. The right ventricle is smaller than the left ventricle, but look at his. This is the right ventricle here. It's eating the left ventricle. It's humongous. So if you volume load this person, they are not going to be able to get the blood back to where they should. And so what else might you encounter, right? So this person is sitting, if you go to an RRT, you might find someone like this. Now this person has a pericardial effusion in here and coming around here, but look at the size of this right ventricle, right? So you see a patient who's hypotensive. What's the first thing that people are going to tell you? Your hospitalist going to tell you, get the fluid going, right? You give fluid to this patient, patient's dead. But then again, you don't know why they died. So everybody's like, well, we tried. But if you put a probe there, you might see this. This is the left ventricle. It's screaming for blood. It's actually screaming for blood. It's saying, why can't I get blood? Well, you can't get blood because the right ventricle is so big. So in fact, a person like this who's in shock, you immediately need to start them on a vasopressor and get fluid out of them. I don't care how you do it. These are the people we would bring to the ICU and immediately put them on dialysis if they weren't peeing. What about this? These are all at RRTs, all done by residents. This is a humongous pericardial effusion. So again, you see this, and what was interesting about this patient is the patient had a PE, so everybody assumed that it must have been another PE. But in fact, it was a humongous pericardial effusion, and nothing makes residents happier when I tell them, go ahead, stick a needle there. And then they drain the pericardial effusion and the patient wakes up. So you might see this. How about this? This is the left ventricle. This thing's not moving. So you give volume to this patient, forget about it, right? Not gonna do well. How about the sickle cell patient? Let's go back. You have the only thing, don't ever let anybody tell you, and I don't know what they do there, but you hear these terms, duplex and triplex. It's nonsense. A duplex, all that means is they do compression ultrasound, but they add color Doppler. A triplex is they do compression ultrasound, they add color Doppler, and then they add what's called spectral Doppler, and you hear the choo, choo, choo. What they have found is that they're worthless, those other two. The only reason they do it is because they get to bill more. So essentially, as long as you have compression, you don't have a DVT. So again, this is that same woman who had the big PE, whose status post pregnancy. So we did this in our patient, and there wasn't one. So we were happy that that wasn't the case. All right, I'm going to give you one more case, and just to show you how varied this is, and then we'll talk for a few minutes. So this was a young male, quite febrile, okay, who had a sore throat, the neck was stiff. He came in, he was hypotensive, had dyspnea, he's hypoxemia, and really bad cervical neck pain. So what do? Well, they called us immediately from the ICU, and they had already ordered a CT chest, neck with contrast, ultrasound of the neck, and an echo. So in 5 minutes, this is what we did. We said, Why is the neck painful? Why is the patient hypotensive? And why is the patient hypoxemic? Well, check this out. We did ultrasound of the neck, and I'll play it here. This is the carotid artery. This is the IJ. The IJ has a clot in it. And if you do it in long axis, this is what it looks like. Does anybody know, before I go to the diagnosis, you can get positive blood cultures and you get a thrombus sitting in the IJ, which is septic, and you get sepsis related to it. It was a classic example. So then we went on and looked. He said, okay, well, that's great, but why hypoxemia? Well, remember, anything sitting in the IJ, if it decides to take off, is going to go to the lungs. So this person had these B lines that were patchy all over the place, and he had these little consolidations right at the pleural surface. And then there was, some areas were normal, some areas had B lines. These were septic emboli. Okay, so B lines were scattered. This was ARDS and possibly septic emboli from a thrombus in an IJ. And guess what it grew? It grew Fusobacterium necrophorum, which is Lemire's syndrome. So we see this on a regular, I wouldn't say we see Lemire's on a regular basis, but we see abnormalities because we just go with the ultrasound where they tell us, right? So what are some other things? The abdomen. This is a huge stomach full of fluid. We started a protocol at LIJ when I was there. When we would intubate somebody, we would first look at the belly, and if it was full, we would go ahead and put a gastric tube in and take it out before we intubated the patient, because if you've ever intubated somebody who aspirates, it's from this. And in fact, this is the gastric tube we put in until we started the suction on it. So what are we looking for? Well, free fluid, hydronephrosis, free air. Believe it or not, I remember when I worked in the surgical ICU, patients would come in and then the belly would get more tense. And I'd say, guess what? There's free air. And the surgeon would be like, how do you know? And I would show them the ultrasound. He'd be like, you can't tell with an ultrasound. I'm like, fine, send him for a CT. It's just going to hold up your operating room. And then they'd send him for a CT and there's free air. And now it was 12 o'clock at night instead of 10 o'clock at night. So you can find a lot of things. So this is ascites. Okay, all this stuff in here is ascites, and this is the bowels. This is what they look like when they get stuck under all this fluid. This is the liver, just to show you what it looks like, and this is fluid. This is in the hepatorenal recess. There's fluid between the kidney, which will be here, and the liver. This is hydronephrosis. Actually, that's a normal kidney. This is hydronephrosis. So you get dilation of the calyces. It's so simple. The pelvis just dilates. This is a big bladder. Someone's not peeing. You wonder why they have bilateral hydronephrosis. Pretty simple, because they have an obstruction to the abdomen, right? This is what it looks like after you put the Foley in. So this was before, this is after. This is the Foley catheter, okay? And this is the Foley catheter even further down. You see, okay, this is a big mass in the liver. This was an interesting case. This was a guy who had a normal CT 3 days prior, and he just kept complaining of a normal CT abdomen. He kept complaining of his abdominal pain. And we went where the money is. He pointed there. We put the ultrasound. So we called radiology, and they're like, well, we just did it. I'm like, well, it's now changed. And this was a big abscess sitting in there. And so last case, quickly, 60-year-old female, shock, fever, diffuse abdominal tenderness, hypoxemia, metabolic acidosis, severe acute kidney injury, elevated white blood cells, severe sepsis. So we look, she had abdominal pain. Well, there is fluid in there. Okay, well, why is the fluid in there? Well, it's not free colonic air, and we'll go over why that is at another time, because I can see into it. If there's a lot of air, you cannot see into it. So what is this? This is ascites. That's what it looks like. Okay, that is the bowel right here. This is ascites right here. And then what? Well, she was in shock. So we looked at the heart. These are huge vegetations that are just flipping around. In fact, they're on the anterior mitral valve leaflet. This is the aortic valve, and it's just going in and out of the heart. And so this, and then you can see it on here, right in here. So this person in 5 minutes, we said, has endocarditis with septic emboli to everywhere, okay? This was another patient in the emergency room. They called, and this was a fellow of mine. They called him. She's on a ventilator, came in, collapsed from her house and they couldn't figure out what was wrong. They couldn't even move her. She was so hypoxemic and so shocky. They said, we don't know what it is. So this was everywhere. This is the lung, everywhere. So no consolidation, no pleural effusion, no hydrostatic pulmonary edema. So WTF, like, why is this? Well, we looked at the heart. This is the heart here. This heart is eating itself, meaning there's no fluid in it. Okay, now there's only 2 reasons why you don't get fluid in the heart. 1, the right ventricle's so big that it doesn't allow it to get over there. And 2, there's just not enough fluid. And why would that be the case? Well, I guess if you run a marathon and you're febrile and you don't drink, but the other one would be hemorrhage. So her belly was distended. Here's the belly and fluid. So guess what we did? We stuck a needle in it right at the bedside. Sorry, no consent was gotten, but I'm not sure that matters. And there was pure blood that was there. And this was the inferior vena cava, which is almost virtual. And so the point is, and this is going to be my last slide, that if you use ultrasound in a whole body approach, and we wrote a paper this long time ago, blah, 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 that suggested that you use your ultrasound to answer the questions that you are asking, you will seek and find, and this is how, we do it. And so I'm going to end there to see if there's any questions. And like I said, if Bethel and Moses want, and there's interest, the way to do this moving forward would be to do them in individual steps. So first we do thoracic, then we do abdominal, then we do point of care ultrasound, and yada, yada, yada. And I'll leave you with only one other thought, which is you cannot get good at doing this unless you take your ultrasound and you ultrasound people. You ultrasound people, dogs, whatever you got, something where there's, movement of organs. And so I'll leave it at that. And thank you.
Thank you so much, Dr. Seth, for that. I've learned a lot. Obviously, like I mentioned before, this type of technology is really important here in places like Uganda, where we need quick imaging to make quick decisions, but also be able to, like you said, CTs and things being expensive for patients. So we have a couple questions. I'm going to start with Dr. Faith. I'm going to unmute you.
Thank you, Bethel, and thank you so much, Dr. Seth. That was a very wonderful focus session. My question is basically maybe regarding cardiac ultrasound. If I do my cardiac ultrasound and I have on the pericardium, I don't exactly have any fusion, but I have what looks like how you would have B lines on a pleural surface, but this time originating from the pericardium. Would that point towards pericarditis or something of the sort? Just could you tell me what that's likely to be?
Yeah, so that's a very good question. My answer would be, the first part of the answer is, once you get comfortable with understanding why we have artifacts, then it won't even matter where you see them. So technically speaking, B lines only come from the pleural surface. That's just the way, the individual who came up with all of this. But the artifact is created because there is an interface where there's either a little bit of air mixed with fluid, or just 2 surfaces that are very different in their echoic ability. And so if you see B lines coming off where the pericardium is, then the likelihood is that there is a little fluid, and maybe there's a little fluid between the parietal and visceral pericardium, which is what a pericardial effusion is, but you just don't know it yet because it's not big enough. So wherever, it also could be a lot of times a little atelectasis of the lung that's sitting right next to the pericardium, that with atelectasis, you get this collapse of the lung, it's just very, very small. And so when the ultrasound hits that, it perceives it as a big difference between the echoic ability, and the ultrasound bounces back and forth, which is what gives you the B lines. So again, B lines from the seminology, from what we actually define it as, come from the pleural surface. Comet tail artifact is the generic term. Again, I could care less whether you call it B lines or not, it's irrelevant. The point is that once you start getting comfortable with the reason that it occurs, you'll be able to make sense when you actually see these B lines. So probably what you're seeing is either a tiny bit of fluid that's stuck in there in between, or you're seeing a little bit of atelectasis that's in there. That's likely. But also, it's just as important to say, if a person's in shock and you're looking for a pericardial effusion and you see a few of those B lines that are there, you can be confident to say, well, it's not tamponade. It's not pericardial tamponade from fluid. Does that make sense?
Yeah.
Sorry, Faith, I was trying to unmute you.
Yes, that makes a lot of sense based on the clinical presentation of my patient. Thank you.
Of course.
Dr. Jimmy has a question next. Let me.
Sorry, I might have a loud background, but yeah. Thank you so much, Dr. Seth, for the comprehensive presentation. I know that there's quite a lot to cover within a short period of time. Focus is quite big, but I think you've really done a good job in trying to rush through all the modalities and all the modalities of point of care ultrasound scan that we might actually benefit from in a setting where we do not easily get a CT scan available. I had a particular question about the pleural effusion that you made mention of in the images that you actually kept showing. And I just wanted to know what should be drained and what can we can say we can still wait for this. This is just like a parapneumonic effusion and might not necessarily need immediate fluorocentesis for that matter. And then right. I think I looked at also the echo for that particular massive tamponade, the tamponade that actually you showed, and the right ventricle seemed hypomotor. In other words, like it wasn't as active. But then when you look hypodynamic, actually that's the word I was trying to look for. It looked hypodynamic, but then the apical part looked quite dynamic. And I'm wondering, in case I'm faced with a situation where you could be having like a combination of a tamponade and maybe a massive pleural effusion, how do we then make distinction anyway? But the good thing is that all of them actually need immediate intervention in dealing with. But then how do we make very clear delineation between the PE and that massive pleural effusion? Because really it looked quite similar to the picture that pleural effusion, massive pulmonary embolism would actually also cause.
So I'm not going to be able to get to everything because I'm going to have to get off the phone, unfortunately, to go start seeing patients. But to answer your first question, the reason why I made it so silly simple is when I see a pleural effusion, I ask two questions. Can I tap it? Well, the answer to that first question is you got to see how big it is. So if you look at a pleural effusion and every time the person breathes, the pleural effusion descends and now you see regular lung in your way, well, it would be pretty hard probably to tap that because you'd probably end up hitting the lung itself. And the second part of that is most pleural effusions that are worth their weight will be big enough for you to tap. So then the second part is you answer the first part, which is, can I tap this pleural effusion? Which is a question to say, is it big enough for me to safely get a needle in? Because if it isn't, then it doesn't matter what you're saying. Either the person has to go to the operating room or it really isn't big enough to worry about. The second part is so yes, I can tap it. Should I tap it? Well, that's your question. In other words, if I have a patient who has a moderate sized pleural effusion that is either septated or simple, but the person's febrile and has pleurisy, I'm tapping the effusion because that's a clinical indication to tap the effusion. In regards to a pericardial effusion and a pleural effusion, there are many ways to distinguish the two, and they become extremely easy once we go through it. And that's the only reason I didn't want to get into the specifics of it, because you raise a really good question that obviously has to be answered, because you don't want to stick a needle into what you think is the pericardium and it's the pleura, and then the other way around. But it is actually pretty easy to distinguish the two once you learn your basic echo. So Bethel, I'm sorry, I think you're there, but
Yes, I am.
but I
I know
do.
you have to go.
Yeah, I do have to go. I
Yeah.
will leave you with, you guys can talk amongst yourselves and with, obviously, with Moses. And, there are many ways to do some of these things, including putting together case conferences where it's just cases and different things. So I'd be happy to help out again. The real awesome future would be if you guys do have access to a machine and you're using it, you get your own cases, and then we have a really neat discussion, regarding what you're seeing. So
Yes, that's what we're hoping to do with you next, actually. So we'll talk about that.
okay,
If you don't mind, I'm sure other questions will be flowing through. I can maybe shoot you an email or a
sure,
text with some of those questions just so that people can have them answered.
sure.
And everyone who's online, this recording will be shared so that you can go back and revisit everything that Dr. Seth talked about. But Dr. Seth, thank you so much for giving us your hour. I really appreciate it. I know
You
we
are,
all do well.
yeah, you're so welcome. Everybody be well. It was a pleasure being here.
Okay. We'll talk soon. All right. So everyone, I think, I don't know if the CPD link was shared, but let me reshare it. And then Dr. Moses will be starting his presentation in a few moments. And the link to this will be shared as well. So I'm going to put all of that in the chat now. I don't know if there are any other questions, or if there are any questions you would like me to send to Dr. Seth, please put them in the chat as well. So that we can be able to send him anything that I can send him anything and make sure that I get back to you with his responses.
Better, I have just an announcement. Members, the CPD link is shared and to be closing the next 8 minutes because we are going to share another link for the second session. So kind of register before it
Benjamin, the link that you've shared for the presentation, is it just his slides or is it the recording as well?
Beth, I think it's for the CPD link that I'm seeing.
There's a link he's sending. He put on here that should have his slides as well. But let me make sure that that is shared before Dr. Moses starts his. And then Benjamin, if you could let us know when the recorded version will be available so that I can so that people can know when to expect that. All right, everyone, Dr. Moses is logging on so that he can start his presentation. And then towards the end of his presentation, I will share the CPD link for that as well as the presentation, his actual word presentation. I'm still trying to find out from the host of Busoga Health Forum when the recorded sessions will be available, and I'll let you know. But as we wait for Dr. Moses, I see people are still putting in questions. Please keep your questions coming. Dr. Seth is waiting. I'm going to send him an email with all your questions that you may have had. So if you keep thinking of them, let me know. Someone is asking if there's no audio, no video. There's no audio or video right now, but you should see Dr. Moses's slides up. We're just trying to get him to be able to log in. It looks like there's an issue with the link, but please let me know if you can see Dr. Moses's slides.
Yes, we can see it.
You can see the slides, perfect. Okay, just give us a few moments.
Yes, we can hear. Okay, all right. So let me hang up on you so that we can start. I can share screen. Yep. Can you share your screen, or do you want me to share mine? Let me.
Okay, everyone, just having a few technical difficulties, but we figured it out. Dr. Moses is able to log on. Thank you for being patient with us.
Okay, I think you're the one sharing. Let me see. Can you allow me?
Dr. Moses, you should be able to share. I've made you a co-host.
Hello?
Yes, we can hear you. Are you able to share your screen? There you go. We see you.
Can everybody hear me?
Yes, I can hear you. Can anyone want to chime in and say if they can hear Dr. Moses?
Yes, we can hear.
Okay, perfect. Thank you guys for being patient.
Yeah, it's fine, Beth.
Thanks, Ronald.
Hello?
Yep, we can hear you.
Hello?
Can you hear me?
Yes, we can.
You're loud and clear.
Yes, we can.
We can hear you.
Hello? Can you hear
Hello,
me?
we can hear you and can see on the screen.
Yes, Dr.
Okay.
Moses, we can hear you. Yep. and
Yes,
see.
okay. So thank you. We've been having, I cannot share the screen because Bethel, you're sharing. So I don't know whether you stopped sharing.
I stopped sharing. You should be able to share.
I still cannot. I still cannot share. So
I'll share for you, maybe. Do you want to do that?
yeah, because only host is allowed to share. Okay, in the interest of time, I think we'll go ahead and start the presentation. So I'm going to be talking about an introduction to non-invasive mechanical ventilation. I'm going to try and make this as simple as possible. I'm not going to present it from a subspecialty level. So you have to forgive me. Those of you who have knowledge of advanced mechanical ventilation, you may forgive me when I make some things a little too simple, but I thought I wanted to appeal to a wider audience with this information. One of my friends was asking me why I decided to present this on Easter. It wasn't my choice. It was the forum. That's the time that they had. But I usually try to joke that God is a pulmonologist. And I use Genesis 2:7, which reads, "Then the Lord God formed a man from the dust and breathed into his nostrils the breath of life, and the man became a living being." This is what we pulmonologists do, is breathe into people's lungs to maintain life. What is a ventilator? A ventilator really is simply an air pump that is well dressed and has jewelry on. It is simply a pump that is pumping air into the lungs. It's very interesting that the first person who had the concept of a ventilator is way back in 1543. This was a smart anatomist. This young man at the age of 23 was a professor of anatomy. Very, very smart, Andreas Vesalius. And this is one of the statements that he published, that life may be restored to an animal if you attempt to open a hole in the trachea and breathe in with, can you imagine, he thought of putting a reed or cane into that area and blowing so that the lungs may rise again and take air. So this is 1543, and you can't imagine how many centuries it took before people started using mechanical ventilation. This is a kind of a representation of him, Andreas Vesalius. Now, this is one of the first attempts at a ventilator. This was created in 1864. This was to try and save drowning victims. Somebody thought about this. Again, these are all systems playing around with pressure in order to allow air to move into the lungs. This one went a long way into creating basically chambers for ventilation. They were using huge pistons and changing pressures within a room where they had actually 5 or 4 patients in order to improve oxygenation. It was almost like you would think of like one of these hyperbaric chambers, kind of something similar to that. This is someone who tried to make it simpler as we are going more and more towards getting the actual ventilators that we're using right now. Now, you can imagine how technology has advanced. This is now one of the commonest ventilators, very small, and I'm going to show you one like that, very small, portable. They have changed life because they are so simple to use. They are so intuitive. You don't have to do much as a clinician when you're managing this type of ventilator. So who needs the ventilator? Two categories of patients: those that need airway protection, patients that are comatose, patients that are undergoing general anesthesia. Those need airway protection. Alcoholics, for example, patients with liver disease who are having encephalopathy, they may need just to protect the airway so that they don't choke on secretions. And of course, patients who have respiratory failure. That's the main group that we deal with that benefits from this. I brought up this slide to show you what difference a ventilator makes. This is at one of the hospitals during the polio epidemics. They were losing patients. Mortality was 87%. And then the day after they started doing tracheostomies and giving positive pressure, it plummeted to 40%. So you can see what difference mechanical ventilation can make in saving people with certain diseases. So what is respiratory failure? Respiratory failure has been used over the last 50 years or 60 years as a diagnosis, and we have advances in monitoring blood gas, so we know what types of respiratory failure we're dealing with. And right now, over 50% of patients in ICUs need some type of ventilator support. And this is the location where we provide mechanical ventilation. Respiratory failure there are two types. Type 1, which is lung failure, where you have problems with oxygenation. And then type 2, which is mainly pump failure. These are patients who have high carbon dioxide, hypercapnic respiratory failure usually. This is the pump is failing to wash out carbon dioxide. Tissue oxygenation. Respiratory system can be organized in two components. The air pump, that's respiratory centers that tell from the brain that tell the lungs and everybody, all the muscles to move so that we can move air in and out of the lungs, the chest wall, the muscles, and conducting airways. And if you can look at all these, things can go wrong at every location here. Respiratory centers, you have a stroke, you're not going to breathe well, depending on where it is involving. Chest wall, you have injuries, you have musculoskeletal diseases, patients with poliomyelitis, patients with many neurological diseases end up being unable to breathe well. Conducting airways, if you have obstruction, and of course the gas exchanger, which is the pulmonary parenchyma, where we're exchanging oxygen. And I'm not going to go into that physiology.
Dr. Moses?
Yes.
I'm sorry to interrupt. Are you sharing your screen or am I sharing a screen? I just want to make sure people are seeing what, because I think I was trying to keep up with you, but.
Oh, you're trying to keep up?
I was trying to keep up with you, but then Zoom is acting weird on my end. I just want to make sure people aren't seeing
Let
a
me
slide.
see if yes, I'm sharing my screen.
I think we can let Doctor share. Let us allow him share.
Is there a way you can stop me from sharing, Benjamin? Because it looks like my Zoom's not letting me do anything.
And yet for me, I'm able to share. I'm sharing.
Yeah, you're sharing, but I don't know if people are seeing me or you, because it's showing me I'm screen sharing too.
We are seeing
So I'm
his
hoping,
screen.
huh?
Okay, Bethel, let Dr. Kitakule just share his screen then to
Right, so I'm
disable.
asking you to stop sharing mine. I can't stop sharing mine.
Okay.
Yeah. Sorry, Dr. Moses, I wasn't sure.
Okay, can you guys see me?
I think I'm waiting
Perfect.
for Benjamin, are you able to get me to stop sharing? Okay, it looks like I stopped sharing.
No, you're
Dr.
actually
Kitakule,
sharing.
you can now share. Dr. Kitakule, you can now share your screen. Are you able to share it now?
Nope.
You
Okay,
can
let me share.
repeat the sharing. Yes, share now. Perfect.
Okay. So I think everybody can see me now. Can see my slides.
Yes, we can.
Okay, thank you very much. And I'm sorry.
And then, Doctor, I can
for
request
the
you, could you
technology.
tap the
Yes.
Doctor, could you tap the record button and record this session on cloud?
Okay. I think it shows recording.
Yes, it is recording. Perfect. Let's continue.
Yeah, it's recording. Okay, so I'm sorry about the interruption. So when do we initiate mechanical ventilation? The most important principle in mechanical ventilation initiation is do not delay. If your patient needs a ventilator, the sooner you do it, the better. You don't want to do it when it is catastrophic. The intubation process can be very dangerous, and for those of you who do not work in environments where you're doing this on a regular basis, it can be kind of terrorizing because patients die during attempts at intubation, and if you fail and the tube is going everywhere and they are bleeding, it can be a disaster. I've seen even the most seasoned physicians and anesthesiologists sweat as the patient is being lost. Within 5 minutes, 10 minutes, your patient is having a cardiac arrest because you didn't do it right. So I always say the best soldier available leads. Okay, if you're trying to intubate somebody as an emergency, get the best person. Of course, when you're trainees, the trainees, you need assistance, but let the best person be there. And that person can be a plan B. Always have a plan B. What happens if I fail? What happens if I fail? And dealing with mechanical intubation, that's a topic on its own, which is very extensive, and I'm not going to go into it. But the most important thing, when you initiate mechanical ventilation, you must have a queen and a king. A queen and a king. And the queens and kings of mechanical ventilation are the respiratory therapists. And actually, I have in the room here, I have Angela. I don't know whether she can come and wave to you. I've just kind of... Yes, Angela is one of our respiratory therapists here. So you need a respiratory therapist to assist you in when you are setting up patients for mechanical ventilation. Now, unfortunately, in the Ugandan setting, for example, we don't have many of these because mechanical ventilation is not very common in most of the hospitals. And one of the things I want to do through Samaritan Health Systems, when everything is in line, is to assist in training more of the respiratory therapists or even training nurses to become the queens and kings in mechanical ventilation, because physicians, we're not very good at managing these ventilators because we are busy, we're doing other things, and we don't keep up. So after you intubate the patient, the most important thing is you select a mode which is simple and safe for the patient. Do not complicate mechanical ventilation, because if you complicate it, people die. Again, remember, this is just a pump that is pumping air into the patient's lungs. Okay, it's just a well-dressed up pump. So I'm gonna kind of talk about the key terms that you need to know. Tidal volume, that's amount of air in mils that you're per minute that you're inflating into the lungs, that you're putting into the lungs. PEEP, positive end expiratory pressure, and PEEP intrinsic. Yes, you need to know about that for patients who develop auto PEEP. But the way we ventilate patients these days, you can get away without knowing what intrinsic PEEP is, because the machine tells you a lot of information. And of course, the FiO2, that's the amount of oxygen, fraction of inspired oxygen that you're going to put into the patient's lungs. Plateau pressure, that's the pressure at the end of your inspiration. That pressure is very important. And of course, the P airway pressure, basically, the name explains itself. And of course, now we talk more about driving pressure, which is the difference between plateau pressure and PEEP. Many of the modern ventilators are going to give you some of this information, like the plateau pressure. When I was training many years ago, we had to measure the plateau pressure by giving an inspiratory hold. You measure PEEP or to PEEP by an expiratory hold. So we had to do these things, but the ventilators these days do a lot for us, and because they are so advanced in terms of the computerization, so it's much easier. Now, what are the modes of ventilation that we normally use? Volume limited. This means you are controlling the volume that the patient is getting. Pressure limited, pressure supported ventilation. And these last two, bi-level positive pressure, those are simple modes of supporting patients, which can be very useful in resource limited situations where people can be saved. For example, if you have somebody who's coming in with heart failure and you know that if you give them a diuretic, you give them some morphine, you do all these other things, within 2 hours or 3 hours, they may be able to survive. If you have access to bi-level positive pressure or CPAP device, you can save that person. And we did use a lot of these devices during the COVID-19 epidemic. Even some patients in Uganda were benefiting from these devices, which are very simple. Now, you have what is called volume-assisted control ventilation. In this, your setup, when after intubate the patient, the setup is very simple. Peak flow rate, usually the respiratory therapist does that for you. A flow pattern, some of these are already standard, whether you're going to have a flow which is square wave or decelerating, and then tidal volume, respiratory rate, and PEEP. And for most doctors, those are the four things you need to set: tidal volume, respiratory rate, PEEP, and FiO2. And Angela will soon show you how to kind of how we normally do it. And when you're initiating ventilation, please use the simplest mode that you're going to start off with. Don't start with advanced modes and then the patient is going to be in trouble, uncomfortable. Start with the simplest so that you settle down. You let the dust settle down. You can think more about the patient, get some parameters read from the ventilator, and then you proceed. No need to be fancy. Okay, Angela is going to show us something briefly, and I'm going to move the camera to I don't know whether everybody can see. This is a simple Hamilton ventilator. I really love these ventilators. They are very simple. They can do a lot. So I've done the intubation. If you can see, Angela has a laminated paper on the ventilator. All our ventilators have on that. This, if you can see, this is a simple table. You guys can download it on internet and print and put on each ventilator if you're having ventilators. It has on the ideal weight information, how to get your tidal volume based on ideal height, on ideal weight. And all you need is the height and the sex of the patient, okay? And for example, if you're intubated the patient and you want to start at 8 ml per kg, let's say, Angela is just going to take a look, find female. Let's assume that this is a male. Angela is going to look, 8 ml per kg, that's where I'm starting, and go ahead. And how tall we said they were? They are 6'5". Let's say 6'2". 6'5" is too tall.
So 6'2", we just follow along. At 8 males, it would be 658 for a male, and then a female would be 622.
Okay, so she can go ahead and set that, and I will, for example, tell her I need a tidal. That's the tidal volume. Give her a rate of 18. If the patient is not in ARDS, I say we can start with a PEEP of 8 and start at 100% FiO2 until we see where things go. Okay. And so she's setting a volume assist control mode. Yeah, and that's it. So that's your beginning. And then you connect the patient to the ventilator. This is simple. And then you see what happens within a short time. You don't have to do anything dramatic. That is a simple thing. And the respiratory therapist will be at your side. Now, for those who don't have respiratory therapists, get nursing champions, nurses that you can train, that can be familiar with these kind of things. Okay. A lot of the RNs, they have been educated in terms of physiology and all that, and they will be able to help you manage, because as doctors, you're so busy running all over the place, there's just so much to do. So assist control mechanical ventilation, in this case, which we've done, you set the respiratory rate, the ventilate, the tidal volume, and then the patient is able to breathe beyond that. The only thing when you're doing assist control is that the patient cannot go beyond a certain tidal volume. And that's why it can be a little bit uncomfortable, but it's usually the simplest mode. For patients who are comatose, if you have intubated and paralyzed the patient, then they are not breathing well at all. So they are not breathing at all. So you can start them on CMV. That's controlled. That means the patient is only getting absolutely what the machine gives, and they don't do anything beyond that. They are usually heavily sedated, and they are not assisting the machine at all. This is what I was talking about, the controlled mechanical ventilation, CMV, complete dependence on the machine. And that kind of setting, you have to be very careful, although now there are mechanisms in the equipment that will tell you if there is apnea, if something goes wrong with the circuits, the alarms goes off. But in older machines, it used to be very dangerous. If somebody was disconnected, it will cause a lot of problems for patients, and patients will end up arresting.
Can I get an ear probe?
Okay. Now, so then I talked about volume. Then you have pressure-regulated volume control. Here, you are setting the pressure. That's what you are focusing on.
Dr. Joy Ngobi, could you mute yourself?
It's us.
Actually, we
You don't know where the probes are. None. I can't get a hold of that phone number I have.
We do have somebody needs to mute.
Dr. Joy Ngobi and Mwanga Victor, could you mute yourselves?
I don't even know what it looks like.
Okay, can you please mute? So I was just talking about a PRVC. This is pressure regulated volume control. You set the tidal volume and the pressure adjusts in order to deliver that tidal volume. So it changes depending on the compliance and the patient's effort. So if the lungs are easily inflated, you don't need a lot of pressure. This theoretically should kind of reduce the risk of injury to the lung. And then there is intermittent mandatory ventilation. Okay, here you set the minimum minute ventilation. Okay, you set the rate, tidal volume, but the patient is able to go beyond that. So if the patient needs more, they get more ventilation on their own. But at least you're guaranteed that they are receiving a certain amount of support. And then there's the synchronized intermittent mandatory ventilation, SIMV, and I think many of you are familiar with this. This is an old-time kind of ventilation, which especially as anesthesiologists use it a lot. Patients is leaving the OR and then they are going to the ICU and you're trying to wean. It's a mode that is easily used for weaning, where you reduce the support that you give to the patient, but they're initiating breath is synchronized with the machine. So it's not just random intermittent breaths. These ones are synchronized and the machine assists the patient. Now, I can't overemphasize this. Stick to the simplest mode and become an expert. Okay? It's that simple. Simplest mode, you don't have to do heroics. You don't have to do heroics because there are many different modes of ventilation. And if you're not in a high volume ICU where you're dealing with 30 patients on mechanical ventilation of different problems, you really don't have. If your patients are simple cases, you don't have to complicate your life. Pressure limited ventilation. In this, you set the maximum pressure. Tidal volume is not set. So which means the tidal volume is variable. And this is very important to know, because in the current thinking where we have, and I'm going to show you this, and this is the opposite side of our paper that we have on our ventilators. It has this the ADSNet protocol kind of settings for PEEP. You should have these on your ventilators. If you have a ventilator, this is a simple tool to have at the bedside, where you the doctor or the nurse or the respiratory therapist can titrate the FiO2 depending on the PEEP. The problem with pressure limited ventilation is that you cannot control the tidal volume, but it has been shown to be more comfortable to patients. Oxygenation is better, but one thing that it hasn't done, it has not improved mortality, especially in patients with acute respiratory distress syndrome. Again, pressure limited controlled ventilation, here the patient has no say. So you're limiting pressure, but also you're controlling how much pressure the patient is ever going to get and the rate and the maximum support the machine is going to give. Pressure limited assist control, again, these are modifications of assist control. You can say, look, we're allowing you to breathe on your own, but your pressure is never going to go beyond this. And you can do all these settings if you're trying to prevent injury, because some patients can pull huge pressures and you're worried that they may end up injuring their lungs. So which is better, pressure or volume? Okay. Now, the caveat here, I have worked with colleagues who love pressure support ventilation, and that's what all they use all the time. And that's fine if you're comfortable with it. I'm very comfortable with volume because I'm passionate about the tidal volume. So that's what I use unless I'm failing. So I usually use pressure control as a rescue. I'm failing to ventilate the patients. I've tried everything, paralyzed them, done everything, but I'm still failing. Then I go to pressure control, or I use APRV, which I'll talk about shortly towards the end. Again, I'm going to tell you this ad nauseum. Familiarity saves lives. Make it simple. Most of our patients who need ventilation, they want you to just support them for that period of 3 or 4 days without causing them harm until their body takes over. That's all. They just want you to guide them through the storm without causing them any harm. And if you make things simple, you're going to save life. Okay, now you have intubated the patient and you have initiated. Angela has set the settings for you. You started at 8 ml per kg ideal weight, and your aim is to eventually go to 6 ml. The lowest, the lower, the better. So you make sure the patient is comfortable. Make sure your sedation is okay. Make sure they are restrained if they have to. Make sure the work area is safe, and confirm the endotracheal tube is in the right place. Okay. Of course, you would have osculated. Make sure that the tube is in the right place. And new ventilators these days, like the one that we have, has actually an end-tidal CO2 monitor that we connect on the ventilator, and it can, Angela can show you a little bit. It can help monitor your continuous CO2, and you could know that the tube is not in the right place just by monitoring end-tidal CO2. You can know, look, if my end-tidal CO2 is 10 and things are not, the patient is not doing well, I may have to check what's going on with my ventilator, with my ET tube. So check gas exchange and ventilation with arterial blood gas test. If you don't have arterial blood gas, you can just use pulse oximetry initially. Now, you have to monitor for early complications. The patient has just been intubated. Patients get pneumothoraces after intubation, so you have to be on the lookout for those immediate complications. If you're giving too much volume, they become hypertensive. There are some complications which our anesthesiologist friends know about post-intubation. Some patients become hypertensive, some hypotensive. People can even get cardiac arrest. How do you set your FiO2? Always think about what was the patient requiring before we did all this. If the patient is being intubated for airway protection, they have good gas exchange, nothing wrong with their lungs, don't give them 100% FiO2 for a long time. Remember, oxygen is a toxin. Too much oxygen is dangerous, okay? So just give them only what you need. And it doesn't take long at the bedside. The things are settling down. You tell your respiratory therapist, please wean the FiO2 as quickly as possible, okay? So that by the time you have to do an arterial blood gas 30 minutes later, the patient is on the appropriate setting, okay? If you're unsure, start high and then rapidly go down, okay? Don't set it and forget it, okay? I've received some patients in the past from the emergency room, for example, and they had been on 100% FiO2 for 7 hours. That is dangerous to the patient because oxygen is toxic, okay? Tidal volume, I showed you the landmark ADSNet study, which clearly showed the benefit of low tidal volume, okay? All this information is available to you online. You can get these tables and put them at the bedside in your ICU. For those who are working in the ICU, you are aiming for the lowest possible tidal volume that's going to allow you to oxygenate the patient, and you're going to manipulate your PEEP in order to get a good setting for your patient. So put that table on the ventilator and use it wisely. This is more of the study that shows high PEEP and low PEEP. This is just a summary from American Thoracic Society. These are their recent guidelines that came out, which are just emphasizing the same thing. So patients who have ARDS. Now, depending on where you practice, ARDS is not a common thing. But remember, you can also get ARDS because of the things that you've done, okay? The ventilator itself that you're using can end up leading to ventilator-induced lung injury and therefore ARDS. For patients who had good lungs before they went to surgery, they come back and then 2 days later or 48 hours later, you have whiteout of the lung from ventilator-induced lung injury. These are some of the things I'm just like to emphasize: high PEEP, prone positioning, but again, lung protective ventilation. And what is interesting now, it doesn't matter what the condition is. Low tidal volume saves lives, even in post-bypass patients. You know, a lot of patients in all different ways of ventilation, or different indications, do not need high volumes. Okay, and this is one of the problems that we've been facing, passing out this information to other specialties. It says, look, in this day and age, a patient should not show up in the ICU when their tidal volume is 750 or 700. You're injuring that patient. The more is, you have to remember, more air does not mean benefit to the patient. It's most of the time it just causes injury to the patient. Okay, this is a summary about lung protective ventilatory strategies. That's what you should focus on, the lowest tidal volume possible. So aim to reduce tidal volume in order to save your patient. Now, these, I call these the fancy modes, the APRV, airway pressure release ventilation. And we've used this before. I've used it in patients as a rescue maneuver in patients who ARDS patients, especially COVID-19. You have to be smart about it and be at that bedside. I honestly, if you don't have a high volume ICU with a lot of patients with ARDS, if you don't know it, your patients will still survive. Okay, but again, this you set high pressures. There is what is called P high, P low, T high, T low, P high. That's the constant pressure that you give. Say you say I'm putting the patient at 30 cm, and then T low and P low, you drop say 5. The difference between those two is when the patient is receiving tidal volume. Usually the time, which is the time where you're using high tidal volume, usually is much longer than the T low. So for example, I will say T high is 5 seconds and T low is 0.5 seconds. Okay, so the patient is getting high pressure in the lungs. The thinking is you are recruiting, but it has some issues. People have been able to tolerate it, but remember, you're not controlling your tidal volume at that time, and you could easily cause barotrauma. There's high frequency ventilation. There is no need to know about this, honestly. It has been debunked. It doesn't work well in adults. Kids, totally different story. Okay, now mechanical ventilation during anesthesia in adults. Again, some of you may be receiving patients from the OR, or you're taking care of patients in the OR. The thinking is really the same: less volume, avoid too much oxygen. And some anesthesiologists use more pressure. These days, a lot of procedures are done using a spraglottic airway, laryngomask airway. Very convenient for some simple procedures. You don't have to intubate the patient. This patient do well when you give them pressure support. But again, it's the same. And again, to the anesthesiologist, focus on what you normally do, what you're used to, make it simple, and patients will be well. Again, with oxygen, easy does it. You can injure patients with too much oxygen, which they don't need. What are the complications of mechanical ventilation? Pulmonary. Again, this is an extensive field. I'm not going to go into it in too much detail, but we are trying to prevent barotrauma, pneumothoraces. You're trying to prevent, because patients can get pneumomediastinum, subcutaneous emphysema, pneumothorax, etc., and even pneumopericardium. The other thing is ventilator-associated injury. That stress, too much stress, when you're stretching the alveoli so much, they will end up getting inflamed, and you end up into trouble. Of course, pneumonia, ET tube complications, getting blocked, and migration. The tube may migrate. You may have left the tube at 22 centimeters to the lip, and the next thing you hear, it is at 17, and it's in the right mainstem. Oh, it's above the vocal cords. I've had to reintubate many patients when the tube has migrated above the vocal cords, or the balloon is above the vocal cords, and the respiratory therapist is telling you, look, I'm inflating the cuff, but I'll still get a leak. And if that is happening, then you think, look, most likely there's the balloon is above the vocal cords. And usually I take a quick look with the bronchoscope, and we can adjust the airway accordingly. Muscle weakness, reduced mucociliary motility, and of course, there are the non-pulmonary cardiovascular hypertension, venous thrombosis. There's also an issue of ulcers, GI issues, and a lot of these are related to the disease that made the patient end up on the ventilator. Weaning, that's for another day, because that's just too much. Okay, we'll discuss this another day. I don't think it's really necessary. And with that, happy Easter. If you have any questions, please.
Thank you, Dr. Moses. If you have any questions, please raise your hand, and then you can unmute yourself so you can ask any questions that you may have. Again, thank you for dealing with our technical difficulties. I'm also going to share the slides here as well. I've been told that the recorded sessions will be available on Monday. So I don't know how Busoga Health Forum usually dishes those out, but we will have those ready. Does anybody, Sophia, you can go ahead and unmute yourself and ask your question.
Okay, thank you very much, Dr. Kitakule, for that presentation. So I just want to seek some clarity. Usually in patients with fibrous lungs, what I've been knowing is you want to aim for more of the pressure modes as opposed to volume. So I don't know if that's true or you can actually use the volume, because in that whole case, they were talking about like the tidal volumes. You can force a large amount of air into lungs that have actually like less space for the air, something like that.
Okay.
Because of the fibrosis.
Okay, so let's quickly talk about two types of lungs. For example, if a patient has pulmonary fibrosis, if you notice the patients with pulmonary fibrosis, the way they breathe, they take in small amount of tidal volume very fast. They usually breathe very, very fast. So they kind of give you an idea what they need. If you're sending in low tidal volumes, you're likely using low pressure. Okay, because in order to use a high tidal volume, you're going to use a high amount of pressure. Remember, I mentioned that there is also what is called pressure limited assist control. You could provide assist control ventilation, but at the same time limit the maximum pressure that the patient is going to get. Okay, but if you aim for a low tidal volume, you're not going to go wrong. Now, the patients, there's another group of patients. Those are the patients who have COPD. Those are the patients that may actually benefit from you aggressively trying to control the pressure, because they usually get auto-PEEP. Their lungs are like balloons. There's no room. And if you keep pushing in air, pushing in a lot of volume with pressure, the balloon is going to pop. Okay? They're going to end up having severe air trapping, and you'll fail to ventilate them because you have no room, because the air they have in is not coming out. And you just keep adding. Again, those are patients also that may benefit from controlling the pressure that you're giving them in order to avoid injury to the lungs. But having pulmonary fibrosis in itself, there's nothing wrong with using volume control, even if somebody has pulmonary fibrosis. You just have to be careful with the amount of volume that you're giving them, because they easily get pneumothorax, because you keep stretching, and then you injure the lung.
Okay, thank you very much.
Joy, you can go ahead and ask your question.
Okay, let me see. Is that Joy Ngobi?
Yes, Joy.
Hey, Moses, thank you so much. I think this is priceless, in my opinion. My name is Joy Ngobi. I am an anesthesiologist. So, because I do a lot of mission work up country in Busoga. And I think the challenge is we don't have trained people to do what we do. And I'm also sure we don't have ICU doctors. So I'm just wondering, in a broader spectrum, Moses, have you inquired whether there are plans for training of respiratory therapists? Because I think that would be a really, really the safe way.
Yes, from a government standpoint.
Does MOH have a plan? I mean, I'm sure there are people here from MOH.
Well, if there's anybody they can say, but I don't know whether the government has a plan, but I have a plan.
Amen.
That's all I can say.
So how can we help you? How can we help you get your plan passed in Parliament and implemented?
And my view, Joy, is that it's very difficult to start, because a respiratory therapist has to do 2 years of basic and all that. I think for the country, in order to rapidly catch up and create a cadre of trainees, the best group to start training are actually nurses. Okay, because they know the other basic science until you're able to set up respiratory therapy schools and where people can say live senior 6 and say I want to be a respiratory therapist and go do a 3-year degree or something like that. But for now, in the interest of establishing the profession, my view is train nurses. That's where I would start.
Okay, I agree with that, and I think there are pathways for that too. I know two options. Dr. Professor Kawoya actually just opened up his university, Ernest Cook University, and he's looking for connections like this. So I think we should meet with him. I'll be meeting with him in a few weeks here, but you should join that conversation and you talk about that because he's introducing new programs. And then the other option we have is in Nairobi at Kijabe Hospital. They do train, and it's only 18 months for nurses. So what you're thinking is the right thing to think about. They can train nurses for 18 months, and they will be ready to fly.
Yes. Okay.
So I think we just need to look for money. We need to lobby for money from the government.
Yeah. Thanks, Joy.
Okay.
I always appreciate your passion for these things.
I'm tired of Ugandans dying, I think. Yeah.
Any other questions?
Thank you. Thank you, Dr. Joy. Any other questions?
Of course. Okay. What's that?
Okay. So
somebody had wanted, excuse me, somebody had wanted to zoom in on the ventilator.
Yes, I was about to make a comment about maybe before you go, if you could do a zoom in of the actual ventilator so people can see the different settings.
Yeah. Can you see? Can you see?
I think that's a bit better.
Just a bit better?
Yeah.
Yeah, so I mean, Angela can show you how you choose the modes. You can.
Yeah, on this particular vent, if you hit modes, it shows you your different options that you have. And for the most part, we use the controlled mode right here. And then you would just select it on whichever mode that you're wanting to use. And then we just have to make sure that we confirm it. It's already in that mode though, so it's not gonna. And on this particular machine, we can do multiple things, which is nice.
And you see, this is a very economic ventilator. It is easily portable. The patient can go to CT with it, you know. You just put a cylinder of oxygen at the back. You could just
we have the O2 tank that we can take with us to where it's portable, and it runs off of a battery so that we can take the vent everywhere as we need to go. As long as we have enough oxygen to get us to.
So this is a ventilator that can transport a patient, if you have enough oxygen, can transport a patient from, say, Jinja to Kampala, if you have enough oxygen cylinders, you know.
Yeah, that's your controls where you set your rates, your volumes, your O2's all right there. And we have our alarms, which you just adjust based off of your patient and what their needs are at that time.
And just to make a comment, again, as doctors, you should kind of stay away from these other buttons, okay? For patient safety. I'm just going to give you an example. When I was just starting to train as a pulmonologist, I remember changing the setting on one of the patients. And the alarm starts going off. I walked away. And I go back. The patient is in extremis. The nurses are saying, what happened? What happened? Because I had touched some buttons which I wasn't supposed to touch. Okay? So make sure you leave some buttons for the respiratory therapist. If you want to change the settings, if the machine is alarming too much, you can say, you know what, is there a way we can change the alarm for this? One of the commonest one I usually tell them to adjust is the apnea interval. If patients are being overventilated and you're trying to get them off the ventilator, at times they become apnea.
She's sleeping.
Okay. and you may have to increase the apnea interval in order to allow them to be weaned successfully. So, but again, that's a discussion for weaning. I don't want to go into those details.
Dr. Moses, I have 2 questions for you from
Yes.
Dr. Jimmy and
Yes.
Mulama. Dr. Jimmy, go ahead and unmute yourself and
I thought I had actually again answered myself. I was just thinking through. Thank you so much, Dr. Moses. I think the presentation was quite awesome for the beginner in mechanical ventilation and also for those that have been really doing it. Yeah. So I know that there's always a temptation to see our patient saturating as high as 100. And you make a very good point on titrating our FiO2. You made a point that I think there was a time when they brought for you a patient from the emergency room and had been kept on very high FiO2 for over 7 hours, and felt like it was really not necessary. And the question there is like, how often should we be actually titrating? And I know that it's also patient based on what SpO2 you want to keep them at, but how often and how rapidly should we keep titrating our FiO2?
Well,
Thank you for the presentation.
Yes, Jimmy, as rapidly as possible. The thing is that many times the manpower does not allow. But what, for example, we do in our ICUs, the RNs can touch that button where they decrease the FiO2. If somebody is citing 96%, 15 minutes later, 96%, then you win the FiO2. You can win in 5 percentages. You know, they're 100%, drop them 95 or 90%, see what happens. And then you have to be aggressive with weaning, okay? Because oxygen is toxic. Don't set it and forget it. You want to keep the patient on the minimum oxygen they need. Interesting, for example, we used to give everybody with acute MI oxygen. Now, research says it's dangerous. If you're having an acute MI and you don't need oxygen, don't get it. Don't put it on, okay? And you have even some families complaining they don't even give him oxygen, okay? Because we're used to that. And if somebody's having a heart attack, they must be having oxygen. But not everybody who is having an MI needs oxygen. So titrate as rapidly as you can. And this is something the nurses can do, okay? As long as you have given them simple parameters. Again, remember that table, that PEEP table at the end. You know, it has what you need to do, okay? Rapidly wean your FiO2 and wean your PEEP also accordingly, okay? And as long as you have this at the vent, they're not going to do anything wrong. They just look and wean, look and wean.
Dr. Moses, thank you. Do you have time for one more question?
Yes, I have nowhere to go.
Okay. Mulama has a question. You can go ahead and unmute yourself and ask your question.
Okay, good evening all.
Good evening.
I am Stephen Mulama from Kenya.
Okay.
And I'm a physiotherapist.
Okay.
And I have got a chance to work in an ICU.
Mm-hmm.
But I had a challenge at that particular point because sometimes I didn't have the knowledge to understand at what point does a physiotherapy come in. For example, sometimes our ICU over here, we don't have maybe a respiratory doctor.
Okay.
So we will be called in maybe as a physio to do the chest physiotherapy and other things.
Okay.
So my question is that at what point do you advise a physiotherapist to come in when a patient is maybe intubated or in any sort of distress? Thank you.
Okay, so you have physiotherapist or respiratory therapist?
Physiotherapist.
Physiotherapist. Well, so I think your role is to sound the alarm. Okay, your role is to sound the alarm. So I think all you need to know is the basic things like pulse oximetry, oxygen saturation. That is a very simple bedside data that you can use to know that somebody is in trouble. And of course, what you need to familiarize yourself is respiratory distress. somebody who's struggling to breathe. That is very easy to pick up. They are swelling many times. They are having paradoxical abdominal movement. The belly is moving in, the lungs are moving out. Not good. Okay, they have flaring nares. Not good. And of course, you who works in the ICU, be aware of the alarms. Okay, you can, as I said, your job is to sound the alarm. If a ventilator is going off and people are having chai and they are not listening to the ventilator, your job is to say the ventilator is coming, is alarming. Can somebody check on it? So there's a role that you can play. And the other thing is that since you're a physiotherapist, you have to protect the airway. Okay, that's one thing because the doctors may tell you to do exercises for the patient at the bedside. Always be aware of the airway when you're exercising a patient who is ventilated. I've seen many patients accidentally extubated, accidentally disconnected from the circuit system by well-meaning physical therapists. Okay, so that's one thing that you have to know. How do I protect the patient who is on the ventilator to make sure that that they don't lose the circuit? And of course, your role in all these patients is to make sure they get physical therapy. Early ambulation and exercise for patients on mechanical ventilation is very important. Remember the tiny ventilator that I showed you? I'm a proponent of exercise. Some people these days, people even have bypass and start walking within 6 hours after they are awake. That's how people are aggressive, and that's why you come in as a physical therapist, because it can help improve outcomes for your patients. Okay.
I think that answered that question. Dr. Moses, this is a very big question, I think. But
Yes.
someone is asking about the role of BiPAP. And when exactly do we use it in pulmonology?
Okay. Yes. BiPAP is very, very important. We use BiPAP. We usually use BiPAP in patients with obstructive sleep apnea. I'm a sleep specialist too. Okay, it's actually BiPAP. BiPAP, that is a trade name for the company. That company, whoever started it, is very smart. BiPAP is not the way you call it. It's BiPAP, bi-level positive airway pressure. Now, in pulmonology, it's useful, number one, in patients with obstructive sleep apnea. Number two, it can be used to assist patients, for example, who have COPD, who are coming in, they have respiratory distress and all. It can help prevent endotracheal intubation. Okay, I didn't go into much details of it, but it can be a bridge that helps prevent, and especially if you're in a small hospital, BiPAP devices are cheaper to have than ventilators. And you can use to save people by just putting them on BiPAP for people who are able to protect their airway. Remember, it's unwise to use BiPAP in somebody who cannot protect their airway, because if they vomit, they will aspirate and die on you. So, or if they pull it off, they are confused, they'll become hypoxic and die. So use it in somebody who is able to protect their airway. But it can be used. All BiPAP is two different pressures. One of them is inspiration and the other one expiration. And the difference between the two helps to ventilate the patient. So for example, if I set a BiPAP setting of 15/5, that 10 is what is ventilating the patient. Okay? If you put the patient on 20/15, only 5 is ventilating the patient. Okay? But yes, you can use BiPAP. If you don't have resources, you can use BiPAP. We used it. My team in Uganda used those BiPAP machines to assist patients during COVID-19. Okay? So you can, and CPAP is continuous pressure. You can also use CPAP to prevent intubation. Patients with heart failure, for example, who have pulmonary edema, you put them on CPAP for some time, you may be able to prevent intubation. In outpatient setting, BiPAP, CPAP, we use them for sleep apnea. Some patients with COPD can use BiPAP even at home to assist them with ventilation. Because now we do have BiPAP machines that have a backup respiratory rate. But I think that topic is better discussed in extensive detail under non-invasive ventilation. All right.
Did we lose them?
Yeah, I think they got disconnected. All right. Any other questions? I
Can
think
you-
Joy is.
yeah.
Does Joy seem to have a question?
I think her hand is still raised.
Yes.
The other question, okay. I think maybe, I don't know if it's a question. Someone was just saying they have their challenge is manual bagging when they're transferring a patient, which manual bagging, even with a still patient, some people don't do that correctly. So I don't know if you have extra tips or expert tips on how to bag correctly while transferring a patient, because a lot of people, that's all they have, is being able to manually bag.
Yes, when you're manual bagging a patient, yes. Of course, it's exhausting. You're going to get tired. The other danger when you're manual bagging the patient is if you may be able to have obstruction of the airway without knowing, okay, because the tongue will fall backward, and if the patient is alert and you don't have an oral airway in, it's not going to be successful. Now, the patient who is being bagged with transport is likely to be the patient who can benefit from a BiPAP machine. So if you have an ambulance service that transports patients with bagging, you might as well have BiPAP machines, because you can have those in your ambulance and put on a BiPAP machine to transport your patient. Okay? Because these BiPAP machines have adapters where you can connect oxygen to them. Okay? And these days, we will receive many patients in emergency room transported on non-invasive ventilation, which are essentially BiPAP machines.
Thank you. I think maybe if you have to bag while transferring a patient, like Dr. Moses said, having in an oral, if the patient is indicated for an OPA, making sure you have one in, that will help with the tongue not blocking the airway. And if possible, 2 people. If not, then yeah, you're just gonna be exhausted doing it one person, but 2 people shares the work.
And then the other thing also, you have to have your suction ready to go. Because if they vomit, we're transporting them and you're bagging them, it's a disaster.
It is. Okay. Are there any more questions for Dr. Moses? I'm looking through and I think we have answered everything. Obviously, everybody's really excited to hear about your ideas of training critical care nurses in respiratory management.
Yes, yes.
But yes, so if there are any more questions, please raise your hand or put them in the chat. But if not, then we might be able to end the session here today. Like I said, I've put Dr. Moses's presentation slides in here if you would like to look over those again. The CPD link is also in the CPD link is also in the chat as well. But the recording, I believe, will be out on Monday. So as soon as that is out, then yes, Dr.
I'm just gonna make a comment. Dr. Joy was saying that the tube should not be the problem. The tongue should not be a problem when the airway is in. I was assuming that you're bagging somebody who is not intubated.
Yes.
Okay.
Yes.
If your patient is intubated, the only thing that you should avoid while bagging them, yes, and my queen here, Angela, is saying, don't overventilate the patient. Okay. Don't hyperventilate the patient. Okay. Easy does it. Okay. Easy does it. Okay.
Go by our motto, what would Moses do? That's our motto. What would Moses do? Anytime I'm sitting on my bench, what would Moses do? That's what I live by on my fence.
Yeah, hyperventilation is an issue. Yep. And squeezing too much air. Gotta go. Okay, I don't think there's any more questions, Dr. Moses. I don't know if you have any last remarks.
Yeah, I just have to apologize for the technology, whatever. I hope we can do it better next time. But I had problems with Microsoft. Okay, so and we had these issues. But
yeah. But thank you. And I think we're hoping we can do more of these in the future. So you all can keep an eye out for that, having more of these types of lectures. And if Dr. Moses is able to make it into the country, I think maybe even doing some in-person presentations and demos, I think would be very helpful. Some people had made some comments about training nurses and then not having functional ICUs, but in my opinion, being here, I've seen a lot of really good equipment and no good professionals to go with the equipment. And so then we end up having equipment that sits there and nurses that don't necessarily know how to use it. So I'm very thankful that people are understanding that nurses need to be empowered to know how to react in situations like this, even though we don't have respiratory therapists per se. Yeah. So, okay.
Well, thank you. Happy Easter to everybody.
Happy Easter. Happy Good Friday to everyone. Thank you for joining. Like I said, CPD link is in the chat and Dr. Moses' slides are in the chat as well. Have a good night.